Hi, my name's Jim Early, and I'm honored to welcome you to the OI Foundation virtual conference and dental session. My grandson Matthew was diagnosed with OI in utero and was born with OI type 3. Matthew has been through hundreds of fractures and multiple and very serious surgeries, so we know what it's like to be a family living with OI. He's now 18 years old. I know firsthand the value that the OI Foundation provides to the families, and I'm honored to open today's sessions on behalf of the OI Foundation Board of Directors. We are very honored to be joined today by Dr. Jean-Marc Retrouvey from the University of Missouri in Kansas City, Dr. Kevin Ricker, a pediatric dentist from Chapel Hill, North Carolina, and Dr. Joseph Napoli from the Children's Hospital of Philadelphia. Our mission at the OI Foundation is to improve the quality of life for individuals and families living with OI through research initiatives, education, awareness, and mutual support. Programs such as this virtual conference exemplify the dedication of both the OI Foundation staff and the Medical Advisory Council members. These programs ensure that members of the OI community have access to both up-to-date medical information and important social sessions, even during a global pandemic. More exciting still is the fact that we have been able to provide this weekend full of information sessions at no charge to participants. These are challenging and unconventional and unprecedented times, but we are still able to provide programs like this to the OI community. As always, is a challenge how to pay for it. So if you're able, a gift in any amount would be appreciated more than you could know. If you can, just go to the website www.oif.org/donations/virtual conference to make a donation. Again, that website is www.oif.org/donations/virtual conference. And now let me turn the session over to Dr. Retrouvey, who will chair today's session. Thank you.
Hello. It's a long time no talk to the whole OIF family. Last time I was there was in Baltimore 2 years ago, the day my grandson was born, which was kind of interesting, and had the immense privilege of meeting Dr. Kevin Ricker, and also Dr. Napoli, I think, at the medical session. So these two gentlemen are very dedicated to the OI, obviously, a foundation and to the OI population, and I'm very honored to be part of this panel. So in order to respect a time, I will let each of my co-speakers to introduce themselves. And what we've done, we started with Dr. Ricker, who is probably the funniest guy on the bunch. So he's gonna be the icebreaker probably and talk about, I don't know, I think in bones and teeth, and he's a dentist specialist, specialized in pediatric dentistry. So he'll talk about us. Last time was a fantastic lecture, so I'm pretty convinced that he will be doing the same thing. And Dr. Napoli will finish with more of a surgical approach and implants and what we can do for probably orthodontic surgery or implants. So I'll let him talk about that. Myself, I will address the middle, which is the orthodontic and tooth movement potential for OI patients or population. So without further ado, and I'm really happy to see that our panel is pretty popular, and hopefully we'll answer all your questions. And I'll turn this to this session to Dr. Ricker for the next 15 minutes. So Dr. Ricker, it's all yours.
All right. Hello, everybody. I am Kevin Ricker, and I did a presentation. Let me pull up my screen here. Give me just a minute to make it pretty. And so let's see. Everybody able to see? There it goes.
Yes, looks good.
Perfect. Thanks, guys. So everybody who is here has been touched by OI to some degree or another. And just because your bones aren't doing the best work that they could do, people also have mouths. And to that end, I titled my presentation, "My Child Has OI and a Mouth. What Should I Expect?" And you might be wondering, why did they pick this guy? And to that end, I am a diplomate of the American Board of Pediatric Dentistry. So I'm a specialist in pediatric dentistry. And I'm on adjunct faculty at UNC School of Dentistry and at another unnamed school down the street with a very problematic basketball program. But what makes me a little bit different than maybe some of the presenters that you're going to see is that I have OI also. My mother had it, and she decided to share with me after she got it from her father. I kept the letter that I found when I was going through a bunch of papers. And Andrew Van Tosh over at Johns Hopkins made the mistake of expecting me to develop normally. I'm sorry to have disappointed him. I decided to become a dentist. So it's kind of the worst possible outcome. Not only do I have experience being on the guy holding the mirror, those are a couple of pictures of me getting some dental work. So on the picture on the left, that's me getting some fillings done and me getting a broken tooth extracted by a classmate of mine in dental school on the right. So I have been at it from both sides of the chair. And what I'm specifically going to talk about is pediatric dentistry in OI. So again, with children. So just to go over the 50,000 foot difference between OI and DI. So OI is a problem with making some hard tissues in the body. It can occur with DI or without DI. DI specifically, dentinogenesis imperfecta, is a problem making dentin, which is the middle layer of the tooth. And it can occur with or without OI. And teeth affected by DI are usually discolored and they are usually weak. Forgive me, because I know you're all, like I saw this picture when I was in the 3rd grade, but really most of the action for DI teeth is in this middle layer. The enamel works okay, the middle of the tooth works okay, but the layer between them, the dentin, is problematic because like the bones, it's not as hard as it should be. Studies have shown that about half the people with OI have problems with their teeth. My anecdotal knowledge of that is that it's far higher percentage of folks with OI having a problem with their teeth, even if they don't specifically have a diagnosis of dentinogenesis imperfecta. And why is it a problem to have soft dentin? Well, when your dentin is too soft, the enamel on the outside of the tooth can be poorly attached to the rest of the tooth, and it's very easy to break that hard layer off that protects and makes the outside of the tooth functional. When the enamel is gone, the tooth isn't strong enough to fight decay or wear or fracture. And so this is what it looks like. This is a patient that I saw with one of my mentors, Tim Wright, over at UNC, who used to be the chair of the department. So on the picture on the left, you can see what a pretty typical DI kid looks like in terms of their teeth. You'll see the teeth are kind of brownish, grayish, and you'll see 3 white ones. Those 3 white ones are where Dr. Wright had tried to wrap some filling material around them that was opaque white, trying to give them a little bit of a better look and a little bit of some resistance to the oncoming wear that they're going to get as they grow up. If you look at the picture on the right, you can get a better sense of what that wear looks like. So on those teeth in the right picture, you can start to see that just by the regular wear and tear of regular chewing and living in this world, the teeth have started to flatten out. They're almost starting to look like trees that have been cut in half and you can count the rings. And that's kind of what the wear pattern looks like in a tooth that's been severely affected by DI. And so you start to see this pattern over time. Taking a look at what they look like on the inside, teeth affected by DI. So I'm going to look at that tooth on the bottom left in the left-hand corner. And that's more what a traditional DI tooth should look like before it really gets broken. You have a kind of a slightly darker area in the middle, which is the squishy part inside. This thicker band of dentin, which is kind of a darker or a lighter gray, and then this nice white coating on the outside. This is the enamel of the tooth, and it is just fine. What happens, though, is it sticks poorly to the dentin underneath and starts to break down. So if you look at the second tooth from the left, on the left picture, the top of it looks kind of almost moth-eaten and jagged. And that's where the tooth has started to break down. And we'll start to see what this looks like. This is what happens over time. Is over time, the teeth wear inappropriately fast. And the outside of the teeth starts to fall apart, and eventually you run into tooth problems. So if you've got kids' teeth, in a kid, preferably, not like in a jar somewhere, that would be super weird. You want to avoid cavities. You want to protect those teeth against fracture. You want to monitor the child's growth and development to make sure everything is going according to plan as you can control. And you want to help avoid social problems by making the teeth look as good as they can. And I'm going to kind of go over these really fast because we each only have 15 minutes, forgive me. But in general, the biggest problem that affects folks with OI and DI with their teeth is regular cavities. The trick is that your teeth with OI and DI are not nearly as resistant to regular cavities as other folks' teeth are. Folks with normal, healthy teeth get problems with cavities and lose teeth all the time. So folks with OI and DI are particularly susceptible because the teeth literally just aren't as hard as other folks' teeth. So you want to make smart choices. You want to drink water between meals. Water all the time is even better. Virtually everything else you drink can hurt your teeth. You want to avoid sticky, sugary snacks, anything that packs into the grooves of the teeth and makes the sugar stick around on them longer. Not things like gummies specifically, or not just gummies specifically, but even things like dried fruit and fruit snacks. Anything that if you ate it, you'd have to take your tongue and clear out the grooves of your teeth with it. It's a good, in general, rule of thumb, you can avoid those. Or if you do have to have them, because these are human children that will always have these things from time to time, go ahead and brush the teeth as soon as you give them. You want to try to brush teeth twice a day. And when you're brushing teeth, you want to be intentional about it. Your job is to scrub every part of every tooth every time you brush. And you want to use fluoride toothpaste. Fluoride is one of the only things that we know that makes teeth harder and less susceptible to decay. And then once a day, get in there and floss like you mean it. And clean out the areas in between the teeth. I would not trust a child to brush their own teeth until they can really give themselves a bath and find all of their crevices and clean them out. That's kind of a good rule of thumb. When they allowed to go solo with toothbrushing is when you think they've got as much manual dexterity as they need in order to really get in there, scrub everything out well. So goal number 2 is avoiding tooth fractures and wear. You don't want to bite on anything that is harder than your teeth. So it's a terrible idea for folks with OI and DI to chew on ice cubes or bite into hard candy. And I am as guilty of this as anybody. The last time I broke a tooth, I had had a pack of M&Ms sitting in my cooler for a while when I was on a hike. I came back to the car and I was like, man, these are going to be awesome. And I crunched into them and split a tooth right in half in the middle of nowhere in Arches National Park in Utah. So I have been there and I've lived that. Don't bite things that are harder than your teeth. And if your teeth are starting to wear down or your child's teeth are starting to wear down, get them covered up with crowns. Crowns cover and protect the entire tooth, while fillings traditionally replace the diseased or broken part of the tooth. So all kids grow up, even me. So you want to make sure that you are monitoring the way that the child grows up, because there are growth consequences to early tooth loss. And children with OI, if you happen to read the latest issue of the Journal of the American Dental Association to learn a lot about this, Dr. Retrouvey's group did an awesome article. They're more prone to having arrangements with the problems with the arrangements of the jaws and the way the teeth fit together. And I have seen some of the slides upcoming from the other presenters, and we're going to talk a lot about this. But you want to make sure that you're being seen by somebody who knows how to monitor growth to avoid problems as they come on, if that's possible. You want to make sure you're addressing social problems with your kids' teeth. People are routinely judged by the way their teeth look. The earlier the treatment is done, the more likely the treatment is to be successful, particularly because with OI and DI teeth, it doesn't take a long time. Some kids, by the time they get to me when they're 3 years old, the teeth have already worn flat to the gum line, and then there's not a whole lot I can do for them. So the earlier you treat teeth, the more tooth there is to treat and protect. One of the biggest challenges you will find is, how do you find a dentist that's willing to treat you? In general, my advice is to find somebody who's done more training than just dental school. When you go to the dentist, and it's a general dentist or a family dentist or a cosmetic dentist, in general, that's a person who went to 4 years of dental school and then a year or two, possibly, optionally, depending on where you live, of extra training in general dentistry. And often they are great, but often those folks didn't have a ton of experience treating medically interesting folks. And they're going to maybe a little more hesitant to jump right in there and say, oh, I got this plan, we're going to fix your teeth up. So if you can't find someone who is a specialist in dentistry, you might see whether or not you happen to live near a dental school, where those folks are often more willing to take on medically interesting patients. If you happen to go to a place, or you're in an area, major metropolitan area, where you are seeing doctors that see a lot of OI patients that share your geography, you might want to ask them where they're getting their dental care done. And then as far as pediatric dentistry, you want to make sure that your child has a dentist by the time they hit 1. Because again, the earlier that treatment is rendered to those teeth, the more likely you are to hold on to those teeth until they're supposed to fall out when the child grows up. But don't forget that OI is a rare disorder. And that means you're probably not going to roll into the dentist in your neighborhood and have him be like, oh yeah, of course I know OI. I've got like 40 patients with OI. It's a rare disorder. And so you're not going to find somebody who's seen a lot of those patients unless you happen to be in some rare and unusual circumstance. What you want is someone who is trained in and experienced with solving complex dental problems, even if it's not specifically your specific complex dental problem. They can usually figure it out. So in general, a specialist is the kind of person that after dental school decided there was one particular thing they were really interested in. And so they did either 2 to 6 years of extra training just in that thing. You might have somebody like Dr. Napoli, who was an oral surgeon who went through extra time in learning about treating trauma to the face, growth and development problems in the face, getting teeth out, managing bones. You've got Dr. Retrouvey, who's an orthodontist who's managed growth and development in the maxillofacial complex, all the bones of the face, moving teeth around, bone biology, all that kind of stuff. I'm a pediatric dentist. I did extra training in just treating kids. And there are a million other choices. And then generally speaking, crowns for teeth in children, and really in adults too with OI and DI, are more predictable than fillings. You have more confidence that a tooth treated with a crown, meaning something that covers the whole tooth, is going to last you. Fillings, by only replacing part of the tooth, still don't solve the problem that the rest of the tooth is weak. The earlier treatment is performed, the more likely your teeth are to survive, or your child's teeth are to survive, as long as they're supposed to in the mouth. This is a case that I did a few years ago. This little girl came to me when she was 4, and I saw her under general anesthesia at 4 years old. A kid that needs 20 crowns often needs to be put to sleep to have it done safely and humanely. So she came in, we saw her over at Duke. We put her to sleep, and I put crowns on all of her teeth. This is what they look like. So if you look at the picture on the top, you'll see silver crowns in the back, which is what we usually use because it's a great material to cover up kids' teeth in the back. And you'll see white crowns in the front. The white crowns are made of zirconia, just like your fake diamond rings or anything else. And you'll see 3 on top in the top picture and 2 brown stubs. So I had fixed 19 of her teeth in the operating room, and I had put beautiful crowns on them. There was one that was too short to fix. It had already broken. What happened was they lasted 2 years, and then she fell in the bathtub. And when she fell in the bathtub, she knocked 2 crowns off, but left the others on. This is how short the teeth were when they came to me. You can see that there's almost nothing hanging out of the gums, which means that those teeth didn't have a great chance of surviving a hit to the bathtub. If those teeth had been longer and I had gotten to her when she was maybe 2, chances are those teeth would have had a better chance of surviving a hit in the bathtub. Down on the bottom picture, you can see right there, that's the permanent tooth just starting to come in, and it's also going to have concerns and will also have to be treated. But kids grow up, like we said, and what happens when they need an adult dentist and they have this very complicated mouth? Same guidelines apply. You might want to consider a prosthodontist, and a prosthodontist is a specialty, a lot of people know about oral surgeons, a lot of people know about orthodontists, but not as many people know about prosthodontists. Prosthodontists are specialists in complex adult restorative dentistry. And often, if you can find somebody who that's their gig, they are great quarterbacks for your care. They could say, what do we want this patient's mouth to look like when they're 20, 30, 40, 50, 60, 70, 275? And then arrange all of the pieces that you need in order to get the teeth arranged to do it. So if you need a root canal, they're probably going to have somebody they can call. If you need to get teeth out, they're going to help sequence the extraction of those teeth for maximum effect. If you need to get complex restorative things hung on some implants, they're going to be help people that actually fabricate those appliances and help hang them on the implants that Dr. Napoli maybe helped install for you. So consider a prosthodontist or just a really comfortable general dentist who is really good at solving complex problems that you're comfortable with and that's helping you make good choices about your own care or your child's care as they grow up. They can coordinate care as needed. And with that, I'm going to stop. That's me in Death Valley a couple of years ago, and I'm going to stop sharing my screen. I'm going to get out of here and hand it over back to Dr. Retrouvey. Thanks.
Well, thank you very much, Dr. Ricker. As usual, very interesting and entertaining, fast-paced lecture. And we really appreciate this. Just looking at the comments from the chat, you have already made a significant impact. And I will now turn to the questions. So I don't know who's in charge of the questions, and maybe
Dr. Retrouvey, we're actually going to wait until the end to do all questions for all doctors.
Okay, so you want me now to jump after Dr. Ricker?
Yes, we'll move right into you.
This is not fair, you know? I'm going to be in trouble there. Okay, should I share my screen?
Yes.
Okay, where do I share my screen? Wait a minute.
Would you prefer us share it for you?
Well, right now, I don't have this option.
Okay, I'll share right now and you just tell me when to move to the next slide.
Give you the option to share the screen because it was working before. Oh, no, it's back on. Do you see my screen now?
Right now, yep. Yep, and if you just do to presenter mode or slideshow.
Okay. All right, so this is the craniofacial aspect of OI. It's a bit different from Dr. Ricker, so I'll be the intermediate between the surgeon and the pediatric dentist, and I'll try to interest you to a different level of looking at OI, the OI population, which for me starts from C2 all the way to the top of the cranium. So 80% of individuals with moderate severe OIs. This on the left side is one of my kids. I put braces on him to this fancy picture. Is an OI1. We treat him with standard orthodontic braces. The lady on the right has, I think she may be on the call too. She has a different type of OI. And the gentleman in the middle has, this is the typical OI, I would say, look of a malocclusion where the teeth don't touch in the back and the front teeth are in front of the lower teeth. So that's usually what we see in many OI patients. And there is no real study, so it's always getting a lot of people asking me, what can I do? All these patients I've seen, that's the kid without the fancy iPhone photo. So he was an OI1, he's an OI3, I treated him orthodontically. This gentleman has OI4 severe, she's OI3. So you can see also the facial structures do change depending on the type. And you can see that this gentleman has a significant chin, and that is also one of the, I would say, prominent features of OI. So I'm not going to bug you with the types, you all know the types, but it's worth looking at the type 1 has some DI, which Dr. Ricker was talking about 20-25%, but usually they present with moderate malocclusions. The type 3, which is the most severe, as you know, have triangular faces, they have significant dental alveolar abnormalities, you have a lot of impacted teeth and a lot of malocclusions. And the type 4 is basically, I would call it at the craniofacial level, because I'm not an MD, so I don't know exactly. But what happens is, in my practice, I would consider the type 4 between the type 1 and the type 3. And we try to get some significant classifications, but at the end of the day, I think the type 4 is someone who's in the middle and has basically a little bit of the type 3 and a bit of the type 1. And all the other types have been added. The type 5 all the way, like Dr. Roche would say, all the way to 19. So there was a lot of types, and they all have different craniofacial anomalies and all different specific needs. But I think, from what I remember, very few of them have DI also. So that, at least for Dr. Ricker, is an advantage, because you can treat the teeth much more easily at the craniofacial level. I'll show you a picture. So this is a type 5, one of my good little patients. I've seen her for almost like 8 or 9, 10 years. She's a type 5. You can see she has no DI, but she also has some significant issues. This is a crazy lady from Quebec. She's actually, she does funny shows and everything. There is nothing wrong about her dentition. She has type 6, multiple fractures, but at the craniofacial level, pretty normal. Type 7, again from Quebec. These are natives from a specific region of Quebec, northern Quebec, that Dr. Roche has identified. And you can see also craniofacially, not much to say. They also have fractures, obviously. But then you go to type 8 and 9 and 10, and you can see now all of a sudden the craniofacial features do change dramatically. So that's very important for us to study, because every single of these kids need to our attention. So what we decided to do, we did some cypherometric studies, and what we're looking at is, this is the, I might move this thing away from me. I'm going to make this smaller, sorry, because I keep, okay. So this, what happens is, this is the cranial base, and that's a typical radiograph of the profile of an OI subject, where you can see now that this is the limitation, the limitation between the cranial vault and the face. And what happens usually is the upper jaw, which is right here. That's the eye in the middle, and the upper jaw right here is much smaller vertically, but also it doesn't come forward as much as it should. So what happens, the lower jaw, which is on the lower right here, will tend to rotate, and you have this very significant amount of malocclusion. And it's basically the standard, I would say, look of an OI subject. This would be considered fairly severe malocclusion, very difficult to treat. And what happens too is the concept, the problem that we have also about the malocclusion of, this is another of my patients. This time we did it in 3D, and you can see the teeth are there. oops, sorry, I wanted to stop this. I wanted to show you something. The soft tissue right here are different. You can see the mouth is overclosed. The upper jaw is very small. So we can look at these patients in a different way. And what happens, I want to show you also what we are looking at the airway also. It's very interesting that because OI subjects, especially the most severe ones, tend to have sleep apnea, and we've been looking at this situation with those type of X-rays. And now we can also look at the malocclusion in different size and different, I would say, different planes. So that gives us a very good idea that the severity, what is very important, and what Dr. Ricker was saying also, is if you see an orthodontist that doesn't treat OI subject very often, the type of malocclusions that the OI patients present are vastly different from the average patient who has buck teeth and has good occlusion. So it's a much more complicated malocclusion to treat, and obviously because the bone is not exactly, as Dr. Ricker was saying, exactly right, well, you have a physiological problem, a biological problem with the bone not responding exactly the way you want, but also the malocclusion is vastly different and something it's very complicated. So this is a paper we published about 2 years ago. Cone beam is the 3D images, and you can see subjects have different morphology. So we studied that, and we could not find really a massive difference between type 4s and type 3s. That's a type 4 in the upper left, a type 3 on the lower right. And you can see that there are some very significant differences, but as a group, they don't look that much different. Sorry. So that's what we saw. That was a very interesting study. We're still working on this to publish more papers studying the craniofacial development of OI subjects. That's another one. Another of my patients. You can see this time she's a bit different from the average, and she has actually buck teeth. She has teeth in the front, so she's slightly different from the average OI subject. But what made her interesting also is she was very difficult to treat, so we are starting orthodontic treatment on her. But this is basically what an OI type 3 or type 4 patients would look like, where only the front teeth are touching. And the profile this time is a little bit less severe than the other one I showed you. It's a very nice picture, but you can see the front teeth are there. The patient actually has only the front teeth to eat with. So as parents, be careful and please check in the back of the mouth of your patients, because I had a patient that I treated orthodontically and he never complained. And OI kids usually don't complain much, and it's really nice. But what happened is when we treated him and we were able to get the back teeth to touch together, he was very surprised and very enthusiastic about eating more food all of a sudden, because now he had a bite. And the mother could not quite understand, but she said, "Why do you tell me this today?" He says, "I don't know, because my back teeth never really touched, so I never knew they could touch." So that's something you have to understand. It's not like these teeth were touching and now they don't touch anymore. It's more that they have never been in contact. So we are working on this to give better bites to our OI population in order at least to get good mastication, to get better digestion, and to get better quality of life, as Dr. Richter said. We also look at the breathing, because a lot of OI severe subjects do report OSA, which is obstructive sleep apnea, but we didn't find anything, and I'll talk to this about in a minute. We looked at the airway, which is the one in color in the back here, different between different patients. You can see this guy here, this patient here has the normal bite. This one has a reverse bite, but you can see that he has more breathing space. So we couldn't find anything really spectacular there, so we're still looking. What about fractures? I thought that for whatever reason, the OI population did not break their mandibles. So the mandible is the lower jaw right here, more than the, I would say, average subject. But look, this patient here called us and had a wisdom tooth extracted right here. And when she bit on something, she broke a jaw right here. And that was very surprising, because there was a large amount of bone. And she said, no, she just bit on something fairly normal. She didn't find it was so bad, and the jaw just broke. So that's something also you have to be careful with your children, is maybe they report some pain in the back of their face or something, have them checked because they may have suffered what we call an airline fracture. That's another one that I got the cone beam from a dentist about 600 miles away from where we live. This patient had seen her before. She had no issues except it's a little bit, you can see the teeth are not growing correctly or properly yet, but she was very young and we were working, and on the top she had an appliance. That's why it's all fuzzy here. So when we took the cone beam again, which is a 3D x-ray, again, the mother said she bit on something, she reported some pain, and you can see she has fracture right here. So the jaw fractures, unlike what I thought, and incorrectly actually, are not as uncommon as we think. So it's very important for you, if you're to give exactly what Dr. Ricker was saying, do not give really very hard foods to your children so they can bite harder, because the jaw, again, it doesn't happen in a very, I would say, all the time, but it's not something that you'll see every day, but it can be seen. And I was surprised, last year I had 3 fractures of the lower jaw. So that's important. So what about sleep apnea? So we looked into sleep apnea, and for the sake of discussion, I will just make a very, very quick statement because this could be a whole lecture. But yes, OI severe subjects have more sleep apnea than the average population. And what happens is sometimes when we do the cone beam CTs, this is one of the patients we saw before, the C2, which is the cervical vertebrae, gets into the foramen magnum, which is the hole in the cranium that gets between the cranium and the vertebrae. And what happens, you have a significant problem. So if your kids report, or you can see that they have some issues sleeping, please have them checked by cranial cervical surgeons so they can rule out this problem. It's very, very important. It's called a cherry malformation, but be very careful, because this one was an interesting one in a sense, this x-ray, because these x-rays come from twin sisters, and they look very much the same. They have the same facial features, but one had this and the other one didn't. So I found this interesting. We referred her for further checks at the Montreal General Hospital, and hopefully something good will happen from this. But I just noticed it, so we basically did the importance of detection. What happened after the fact, I don't know. Okay, so that's the whole idea. So the incidence of sleep apnea or apnea syndrome is significantly higher in patients with cranial vertebral junction malformation, which I just showed you when the density is hitting at the wrong place. So be careful with this. It's something that needs to be looked into, and it can affect kids and also adults with OI. So what do we do to help our patients? That's one of my little patients. It's from Saskatchewan, very nice little kid. And what we do is, that's the patient I was talking about. This patient has a typical malocclusion. He has limited DI. You can see the discoloration of the teeth, but he hasn't broken any. So that's why we selected him as I would say, a pilot study. And what we did is see the amount of open bite. This is over centimeters, and that's significant. So he could only eat on this little piece of tooth, which is try this, and it's not easy to do. So what we did Invisalign on him, and we sent him to the prosthodontist. That's the day we removed the aligners, and then the prosthodontist finished with a little bit of plastic to give him a better bite, and he was very happy with the treatment. And it took 20 months overall. Very nice patient, good result. You don't get the perfect bite that you would get with I would say, a non-OI patient, but then the prosthodontist was able to rebuild the teeth, and then he was fine. Oops, wait a minute. I think there's a problem here. Okay, oops, sorry. So the idea also is, what can we do also for our patients to help them out into getting better? So now what we use a lot, we use 3D printing, which is one of our patients with 3D printed the upper jaw and the lower jaw to better study and to make appliances. So that helps us a lot. We use cone beam x-rays, and we are able to, I would say, get them into this occlusion. And what we do also, I'm treating this little patient from Florida I would say by proxy, where we are using the 3D printing here, and she has a very tiny mouth. You see, that's in centimeters. You can see the mouth is very, very small, and we'll just slowly with the aligners, and that's why you see the little blob of plastic right here. You can see that these are little handles, And they are not brackets, they're just pieces of plastic. And slowly the orthodontist is making this jaw wider and wider and wider because this little kid is growing and we are taking advantage of very light forces. And this can only be done with 3D printing. So that's another project we are working on to develop the jaws of OI subjects using 3D technology. So what about patients with adults? So I'm just going to put a few slides. I'm no expert. And I think Dr. Ricker is right. You need to see a prosthodontist. You can see on the left and the right, that was the restoration of the dentition. The problem is in adult patients, it's very expensive and unpredictable. I would argue that I get a lot of I would say, questions asking me, this doctor wants to do this to me, this doctor wants to do this to me, what do you think? I would argue exactly the same point as before, that you should probably go see a dental school or see someone who does a lot of this type of work, because dentistry is super expensive, and if it fails, it's doubly, first of all, it's painful, and it's painful for the wallet also. So I would say that please, if you are going to be investing in dental implants or crowns and this and that, make sure that you are looking at people who have the expertise, because a lot of people have a big heart, they want to help, but then if the treatment is not exactly rendered the way it should be, then you have failures, and it's really frustrating for the patient. So full crowns, as has been said already. Dental implants, I'll let Dr. Napoli talk about it. All I can say at the moment is the term would be unpredictable. I would argue that on OI type 1 subjects, they work really well. And the more you go towards type 3, the less they will work. It doesn't mean that it will not work, but it's more complicated. And the dentures are difficult because if you lose your teeth, your bone is going to shrink, and it makes the denture harder to be fitted properly. And it's not easy either. So there is no perfect solution. Some people will adjust really well to dentures, some don't. Other dental problems, make sure you have no problems with the gingiva. I've seen a lot of, when I was doing my studies, a lot of gums problems. So again, brush your teeth a lot, use dental floss a lot, try to minimize the amount of inflammation around your teeth. They're already more fragile than the average tooth. So that's a very important aspect of what you can do to maintain your dentition healthy and maintain your bone level healthy. All right. So that's the idea. What we did is the point of care. We did that bone support. We don't know exactly why. Maybe the bone is less strong. Maybe you took biphosphonates. Maybe you took IV biphosphonate. There is no real reason why you should get more periodontal problems. But periodontal problems mean that inflammation around the teeth, but it's important. Okay, and I will thank you on that. I will also just want to make a plug. We are starting in Kansas City a study on Invisalign on OI patients type 4 and 3 with moderate malocclusions. So if anyone has an interest, they can contact me through the OIF, and I'd be more than happy to answer your questions. So that's all I had to say, and and that's the end of the slideshow. And I'm going to stop sharing my screen again, and we'll answer your questions later. So that's what I do. Thank you for your attention. And now I'm going to turn this to Dr. Napoli, who is the oral surgeon. He will introduce himself, because I don't know all his degrees. I'm sure he has a ton, so might as well let him talk about them. And then we'll answer your questions. So Dr. Napoli, the audience is all yours. Dr. Napoli, you can start now. Okay, cool. All right.
Okay. Can everybody see my screen?
Yes, perfectly.
Okay. Okay, so hopefully this will go through smoothly. I've been having some connection problems, but thank you very much, Dr. Retrouvey, for that introduction. So my name is Joe Napoli, and I'm a craniofacial plastic surgeon and oral surgeon at the Children's Hospital of Philadelphia. And I want to welcome everybody to this last session of the last lecture of the last session for the meeting. I've totally enjoyed this and want to thank the OI Foundation for inviting me to speak. And it really is an honor to be on this panel with Dr. Ricker and Dr. Retrouvey. Pretty much most of what they said impacts upon some of the work that I do. So without further ado, let me get started. I'm going to speak about the maxillofacial considerations in OI. And as we learned before, malocclusion, specifically class 3 malocclusion, is common in the OI patients, and we also have to address. I'm going to spend most of the time about the malocclusion, but we'll also speak about missing teeth and what to do about impacted teeth, and all 4 of these things are related. And so facial balance or facial imbalance is something that we address as we address the malocclusion. So this is an example of a youngster with a severe class 3 malocclusion. And on first glance, it looks like the issue is that the lower jaw is too big, but as Dr. Retrouvey mentioned earlier, the reason for this imbalance is that the maxilla or the upper jaw didn't grow. And you can see that a little bit better in the X-ray. The front teeth are way back here compared to where they should be lined up with the bottom teeth. And when you look at this bite, it's easy to see why there could be some functional problems. Problems chewing, problems biting into food. But some of the other functional problems that are not always addressed are things like speech. When the teeth and jaws are not lining up properly, that could affect the sound of speech and have difficulty saying some specific sounds like S's and T's. Now, another functional issue associated with jaw position is breathing. And as you heard from some of the earlier speakers, the shape of the chest and the lung tissue itself can influence the breathing function. And as Dr. Retrouvey and also Dr. Shaw mentioned, some of the sort of spine.
Your mic is critical.
Is this better? Can you hear me now?
Yes, it seems to have gotten better.
Okay. So another issue has to do with breathing. And in addition to the problems with the shape of the chest and the lungs, the cervical spine was already addressed by Dr. Retrouvey and also Dr. Shaw earlier. But another consideration is the shape and size of the jaw. And when you think of breathing, it all starts with the nose. And if the upper jaw and the nose are so far back, that could actually interfere with the size of the airway. So this X-ray on the right can show how narrow the breathing passage is behind the nose, and then it widens up as we get a little bit lower into the windpipe. So this is a possible cause of obstructive sleep apnea, and you can see this young boy, he doesn't have OI, but he has another skeletal dysplasia, required a tracheostomy during infancy. And so to correct this, the entire upper jaw, along with the lower part of the nose, has to be moved forward. And this was done with these distraction rods. And you can see the huge difference in size of the airway once the upper jaw is brought forward. And once this healed, he was able to get his tracheostomy removed. So what are some of the things that we do to address the maxillofacial issues? Well, orthodontic surgery, what I'll spend most of the time on today, is surgery that's designed to correct the imbalance of the jaws. Removing impacted teeth is often necessary prior to the surgery. And then, of course, if we have time at the end, we can spend a little bit of time discussing dental implants. So where does the word orthodontic come from? Well, you know from orthodontics and orthopedic surgery that ortho is generally means straight or aligned, or straightening and aligning. Gnathic is the Latin term for jaw, so orthognathic surgery is surgery to align the jaws. Now, the vast majority of people who have a malocclusion that's severe enough to need surgery, in other words, a malocclusion that can't just be fixed with braces alone, can have conventional orthognathic surgery. And the surgical techniques for conventional orthognathic surgery have been around for decades, and they've sort of tried and true techniques. But there are some situations where conventional orthognathic surgery just won't work. And whereas in conventional orthognathic surgery, the bones are cut, they're moved into the correct position and held with plates and screws. But as I mentioned earlier, there are some situations where the bones can't be moved far enough in one go, and another technique called distraction osteogenesis needs to be done, and we'll talk a little bit about that as well. So starting off with conventional orthognathic surgery, here's a youngster who has a mild to moderate severe class 3 malocclusion. It was one that really couldn't be addressed with just braces. So we decided, the orthodontist and the family decided to look at a surgical option to try to get the bite improved and improve his facial balance. So, so this starts with, full planning. X-rays are done, and these images can be made from a CAT scan data. And so the surgery is planned ahead of time on these images. So it's called virtual surgical planning, and Dr. Retrouvey showed some of this earlier. So the way this is done is the surgery planning is done where we would create a bone cut right about here between the upper jaw and the cheekbone, and then cuts in the lower jaw, either back in here or in here, depending on the situation. And then this plan is brought to the operating room. And so the bones are moved, and what I want to point out here is you can see that the upper jaw has been moved forward. There's a little bit of a bone gap. Now that's pretty small. If this bone is attached to this with a small plate and screw, eventually this will fill in with bone, and he won't need a bone graft. So what that looks like after surgery, you can see these are very, very low profile plates and screws that are left on the bone, and they rarely need to be removed. They usually just stay there, and you can't feel them because they're very thin.
Issues with your mic again, Dr. Knapp.
Okay. Is it okay? So in this particular patient, the maxilla was moved and held with plates and screws. And also we put some wires on the teeth to help stabilize that. We rarely use wires on the lower teeth anymore. Most patients don't have to be wired shut. In this particular case, we did. So, so after surgery, you can see this patient had braces first to get the teeth straightened out before the jaw surgery was done. But you can see the correction in the bite from the before and after. And I don't know if you can actually see the right screen very well because it's cut off on my image, but he's got a much better facial balance and a better occlusion. Now this was a pretty, not what I would say a severe class 3 malocclusion, but not all class 3 malocclusions can be treated the same way. So we saw how this youngster was managed, but this young lady presented with a much more severe malocclusion. And you can see from their 2 x-rays the difference. On the picture on the left, there may have been maybe a 1/4 of an inch difference in the bite. But on the right, the front teeth are more than an inch behind the front teeth on the bottom. So this is a pretty severe malocclusion and can't be addressed the same way. If we tried to do it the same way, this is what we would encounter. So if this bone was cut and you tried to stretch it this far, it probably wouldn't be able to go that far in one operation. And it would also be a lot more risky. The second problem is that there's a huge bone gap here. You can see this big space between the cheekbone and the nose and the upper jaw. this would not heal by itself. If the bone was this far apart, it would require bone grafts placed to get that to heal properly and stabilize. So fortunately, there's another technique that's been developed called distraction osteogenesis. And orthopedic surgeons have been using this for probably since the 1940s. And what they realized is if a bone is cut and slowly moved and lengthened, new bone will grow in the gap, and usually avoiding to need a bone graft. So in the 90s, these principles began to be applied to the facial skeleton. It's a lot more complicated because the facial skeleton, the bones aren't just sort of straight. They have all different configurations. But let me just use these pictures as an example to describe what distraction osteogenesis is. So the first thing that happens is a cut is made in the bone, but the bones are not moved. They're just left in that position and let new bones start to form and let the healing process start for about a week. And then very slowly, after that period of time, once there's soft bone in here, the two bones can be slowly pulled apart. And while the bones are being pulled apart, new bone is forming in this gap. Now, initially, that bone is very soft. But once the bone is lengthened to the right length and held there, this bone eventually hardens and becomes just as hard as the surrounding bone. So that's the principle behind distraction osteogenesis. So fortunately, the bioengineers and some very smart people figured out ways to do this for the upper and lower jaw. And so that technology was applied to this young lady when she came to us to have us look at ways to correct her malocclusion. So you can see how severe her malocclusion is. The other thing I want to point out is she also had dentinogenesis imperfecta, and Dr. Retrouvey and Ricker addressed some of the issues associated with that we encountered when we made decisions about how to treat this particular young lady. So there's a lot of preparation that goes into preparing for surgery for this. We heard a lot about the medical components, so I won't dwell on that today. I did want to spend a little bit of time reviewing the dental preparation. And that most of this is going to be sort of a reiteration of Dr. Ricker's and Dr. Retrouvey's principles. But it begins in early childhood with prevention. If the teeth aren't preserved, then it becomes more difficult to try to correct the occlusion and to get teeth to match up. If there are any teeth that are decayed, they should be fixed. And if they can't be fixed, they ought to be removed, because if a tooth becomes abscessed and it causes an infection, that would be very risky to have that infection occur around the bone that's been operated on. And then if there are teeth that are impacted, in other words, teeth that are stuck in the bone that haven't grown in, they would need to be removed as well. And here's a pretty typical example of impacted molars. Now, a lot of people have impacted wisdom teeth, but in OI, there is a higher risk of having impactions of other teeth as well, like the first molars or the second molars. So this particular young lady had impacted second and third molars, and we had to make a decision of whether or not we would remove the second molars, and we decided to do that because we felt that it would be too difficult and maybe take too long to try to move this tooth into position. And if it was left here, it would damage this first molar. The lower third molars had to be removed because if surgery is planned in this area, you really need to have solid bone, because if the teeth are there, then the jaw will be a little bit weaker at the site that we have to do the operation. So in her situation, these extra teeth, or the impacted teeth, were removed about 8 months or 12 months before her jaw surgery. And then finally, orthodontic preparation is really critical to have the best result you can have. Now, some of the issues with orthodontics, as you heard, are that if conventional braces are put on the teeth, these could be pretty risky in terms of taking the braces off, because if the enamel is not attached well to the dentin, then just taking the braces off could damage the teeth. So you heard from Dr. Lee earlier that there are some research studies going on to look at aligners like Invisalign that Dr. Retrouvey is working on now. And fortunately, we had a chance to use aligners, soft aligners in our patient, and the orthodontist was able to get the teeth into a better position to get her ready for surgery. There's no point, I mean, well, I shouldn't say there's no point, but if we're gonna go through all the work to get the jaws lined up, it would be nice if the teeth matched after all that's done. So that's why we really like to enlist the help of the orthodontist in that phase of treatment. So then it comes time to plan the surgery. So as we saw earlier, this is all done with virtual surgical planning. And so we make the design of the cut in the upper jawbone and then decide how far to move it and at what angle. So how far in length and in width and in height. And we develop a vector. And from that, from the CT scan, we can make a three-dimensional model. This is 3D printed, just like the one that Dr. Retrouvey showed earlier. This is an exact replica of that patient's jawbone. And from that model, we could custom bend these distraction devices. These are the devices that are used to stretch the bone. So this rod here actually sticks out of the mouth. And if you turn this screw at the end of it, it pushes these two plates apart. And when these two plates are pushed apart, it moves the upper jaw away from the cheekbones and the nose. So you get a better view from this next picture here. When all that work is done, it's time for surgery. The operation is done in a way that a very, very thin cut is made in the upper jaw to separate it from the bone above it. And then the bone is not moved, it's just cut and loosened. It's left in the same position. And then this is this picture shows the distraction device put in place precisely the way it was designed on the model. This is the little rod that sticks out that the parents would turn. And we put little rubber tips on the end of them so that they're a little smoother and don't hurt as much when they're being activated. So these are turned once or twice a day, and that's about 1 millimeter. So this X-ray on the left was taken right after the distractors were placed, and so this is the first stage of the operation. As these rods are turned, these teeth, or the whole upper jaw, will move closer to the lower jaw, and you can see on the right the teeth are much better aligned. Now we couldn't.
Dr. Napoli, we lost you.
Go any further. Okay, I don't know how much of that you heard, but these rods are turned and the upper jaw is moved so that the front teeth are in much better alignment with the bottom. So this is the first stage of her surgery. Then we have to wait a while and let the bone heal. So you can see this huge gap that was created by the lengthening of the jaw. After 2 or 3 months, that all filled in with bone, and now this is nice and solid. But we still have some work to do to get the bite fixed. So the second stage was designed. So that,
Dr. Napoli, we
I
lost
don't know
your
if you can
sound.
see the end of this, but this is the bite before.
We lost your sound.
Okay, is it back on now?
Yes.
Is the sound back on?
Yes.
Okay. So the picture on the left shows her bite before any surgery was done, and the picture on the right is after the 2 stages, the upper jaw brought forward and the lower jaw brought back. And you can see these are the small plates and screws that we used to hold the bones together, so we didn't have to wire her mouth shut. And now you can see the correction in her underbite with a nice occlusion in the front. And this is the before and after photo after both.
I think we lost you again. Maybe we should reconvene because it's been 25 minutes already, so I don't know what you want to do.
Stages of three. And this is the frontal view. So, so now what about missing teeth? We can spend a few minutes and talk about implants, but if someone has a missing tooth in the front here, or even in the back, and it's recommended to have the tooth replaced, there's different ways to do it. The simplest way is to use a removable prosthesis. So this is like a retainer or a removable denture that has a tooth attached to it. But the downside is it has to be taken. Place missing teeth was with traditional crown and bridge work. And so what is crown and bridge? Well, what happens is if you got a missing tooth here, the tooth in the front of the spot and behind the spot are filed down so that caps fit on these teeth, or crowns. And these crowns are then cemented to the teeth here and here with this artificial tooth in between. And this, many years ago, was the standard way to replace a missing tooth with fixed bridge work. The problem is it's hard to clean these, and you have to file down two perfectly good teeth very often to get this to fit. So it would be nice if you could make an opening right between these two teeth and put a tooth directly in there. And that's where implants come in. So implants are basically titanium posts or titanium screws, and they're put in very carefully. So very carefully, a hole is drilled in the bone precisely where it should be. The implant is placed and then covered up with the gum tissue and allowed to heal for a few months. Then after a few months, the surgeon will make an opening in the gum tissue, and the dentist could then attach the crown of the tooth. And as you've probably seen, a lot of management for issues associated with OI have to be done by teams, and it's no different with dental implants. The surgeon and the prosthodontist, or the surgeon and the dentist, have to work very closely together to make sure that this is exactly where it should be. And what are some of the risks of implants? Well, the first thing is if it doesn't heal well in the beginning, there's a good chance it's not going to work. Another risk is that even if the implant takes, if it gets infected, if the gums aren't kept very clean, the implant could become loose and it can be lost that way. Fracture of the jaw related to implant is pretty uncommon. And if implants are lost, it's mainly because of the first two reasons and not necessarily because there was a fracture of the bone. How can you reduce the risk? Well, as you've heard earlier from earlier speakers, if you smoke cigarettes, it's probably advisable to stop at least 2 months before, because we do know that smoking interferes with healing. The teeth have to be kept, and the implants have to be kept extremely clean so that they don't get inflammation or gum disease around the implant, because that could result in losing the implant. And as I mentioned earlier, it has to be a surgical team that's very experienced. The role of bisphosphonates is not my area of expertise, but there's probably a different effect of bisphosphonates on whether someone's having orthodontic treatment or implants. And I would just say that if you're on bisphosphonates and need surgery, there should be very close collaboration between the surgeon and the medical provider who's managing that. So how do implants in OI compare to the success rate of implants in the general population? There are a number of reports that show that the patients with type 1 OI have a very similar success rate to the general population, which really is quite good. I mean, it's greater than 90% that the implants will last for more than 5 years. in type 3 and type 4, the reports vary. Some of them I read show that the range of success is less than 50% in some small series, meaning that in 5 years, more than half of the implants were lost. But there are some reports that show greater than 90% take of implants after 5 years. So I would say, and I have to let you know that implants are not a regular part of my practice now. But I would say that, yes, implants have a role in OI, but I would say that it should be done, as Dr. Retrouvey mentioned before, and Dr. Ricker, it should be done by people who are doing implants as a regular part of their practice. And then there's just one more thing I wanted to say about implants, and then we can open it up to questions. Timing. If the implant is successful, it really is locked onto the bone and doesn't move. It's not like a tooth that could be moved around with braces. So if you're contemplating having implants placed to replace missing teeth, it's very important for the dentist and orthodontist and yourself to decide whether or not there's any benefit to orthodontic treatment to align the teeth or align the jaws. And if there is, that should be done first, because once the implant is put in, it can't be moved around. So if there is a malocclusion that is felt that it should be corrected, that should be done first, and then the implant's done after the orthodontics and orthodontic surgery is completed. I want to thank you for your patience. I apologize for some of the technical issues. So I'm certainly happy to answer any questions or go back over some of the slides if you missed them.
Well, thank you, Dr. Napoli. Yeah, the technical issues, but that was fine. Nice presentation. So Jessica, what do you want to do for the question and answer setup, please? You're muted, my dear.
Sorry, can everyone hear me?
Yes.
Hi, everyone. My name is Jessica Ransom, and I'm the health educator with the OIF. I wanted to thank all of our speakers for this session. They've done such a great job, and we're about to begin the question and answer session. We will try to get to as many questions as we can today, and if you have any further questions, feel free to reach out to us at bonelink@oif.org. I'm sure you've seen that floating around in the chat today. We would like to note that this is not telemedicine, but it is an educational session. We are going to do our best to make sure that the questions in the chat are answered today, so let's get to it. So we received quite a few questions in the chat on the topic of implants. And one of the first questions is there an age limit or target age to wait before getting implants for younger children?
So I'd be glad to address that directly. So kind of like Dr. Napoli said, the problem with implants, I mean, there's a lot wonderful about dental implants, but one of the problems with them is once they are placed, they cannot move. And so what you don't want to do is put them in any bone that is growing and maturing, which is why we don't do dental implants on children, because it gets stuck in a fixed point in space. And then as the bones grow and develop around it, you don't want to create kind of an anchor point, a singularity in the bone where the implant is. So what you want to do is kind of wait until a child is done growing. And of course, girls are going to beat guys out in that regard. Girls are usually going to finish before guys. But in general, we want to wait until everyone's done growing before we consider dental implants. It's an adult dental treatment.
Sounds good. And if someone were to have DI, could they still receive dental implants?
Yes. I mean, you mean DI? It has to do more, I think Dr. Napoli would say the same. I think it has to be more of the severity of the OI. I mean, the more the bone is less strong, the more chances of the implant to fail. So that's why he showed a picture, or actually a slide, of a OI type 1 has a 90% success rate, and OI type 3s go down to less than 50%. So I would argue that it has to do, and it's all case report, so it has to do with the person who placed the implants, probably, and also to the, I would say the bone where the implant was placed in. So it depends on the healing process too. So age-wise, I don't know if Dr. Napoli can can add to this. I don't think age is such a problem. It's more like the quality of bone that is more of importance. Am I right, Dr. Napoli, or not?
Yes, I agree. Once you've, as Dr. Ricker mentioned, you really want to wait until they're skeletally mature. But after that, it's a question of the quality of the bone. And I don't know if we really understand completely the role of bisphosphonates. One of the things I've learned from this conference these past 2 days is there's a lot of energy towards doing more research in the craniofacial and dental area, and I'm hoping that we have some studies going forward to look at some prospective studies to look at some of those questions. But no, I agree with you completely that it's the quality of the bone.
I would also add something for the OI population out there. My humble opinion, and that's why we do not get good data for anything in dentistry. I don't know about medicine, because OI populations go to hospital where they are treated into a very selected, well-selected and controlled environment. If you go to your own dentist in North Carolina and you go in Kansas and this and that, basically all the data is totally dispersed, and we can really have a very tough time understanding what we're doing because we can never get large samples. And that's why with the NIH now, we're working hard to get large samples of data so we can help the OI and soft bone populations with better treatment options, because when we have a larger sample, we understand what works best. So that's what I've been fighting for 10 years, is to get dental centers, I've got nothing against the regular dentist in any city, but if he sees one patient with OI or two, it's not helping the therapeutic approach, unfortunately.
That's a great point, Dr. Retrouvey. And Dr. Napoli, could you elaborate more on implants used to hold dentures?
Yeah, so as I mentioned, it's not part of my practice now, but when I first started doing implants in the 1980s, that was really the first indication to use implants. Was if patients had no teeth and the dentures were not stable, you can maybe place 4 implants in the jaw and then attach a denture to that, and the denture could be removed so the implants could be cleaned, but at least the implants held the denture very still. And it was only later when people decided to use them for single tooth replacements. So the original use of implants was to hold dentures. Now in OI, I did see some case reports where implants were used to stabilize dentures. And the success rate's probably going to be similar to what it would be for single tooth implants. But occasionally a surgeon will put more than they need. So if you want at least 3 implants, preferably 4 for a denture. So the surgeon, if they can find a good place to put the implants, they may put 1 or 2 more, because if 1 or 2 implants fails, they still have the other ones that will stabilize the denture.
Yes, and there was a lot of comments in the chat about affordability. And I would, people with dentures or adult patients, I would refer them to the Montreal study from McGill University that has proven without beyond a doubt that if you have a lower denture and only 2 implants with little balloons to help them hold, it makes a vast difference. So usually what they said now is, obviously if you can afford to have 5, 6 implants and get a full, fixed denture, that's fantastic. But if you can't, 2 implants strategically planned, and then you can find the best possible bone area to place the implant, and then only have 2 implants, no bar, nothing, and then have a denture fitted over. It makes a vast difference in chewing ability. That has been proven, and it's called the McGill model. It's been done for like 20 years, and obviously we never did it in OI. It'd be a nice study to do, but I would argue probably it will help a lot of our OI population with dentures, because just 2 implants make a huge difference.
Right. Mm-hmm.
Thank you. Another topic that we received a lot of questions on is DI. And one of the first questions about DI is, do bisphosphonates improve DI?
Probably not. Most of the teeth are already going to be assembled. The bisphosphonates interfere with kind of bone maturation. I mean, they do all kinds of things. They get all over the place. But usually by the time bisphosphonates are being engaged, most of the teeth have finished forming, generally speaking. And if I'm wrong on that, I would love to defer to Dr. Retrouvey or Dr. Napoli. My understanding is most of the teeth have already kind of calcified and developed their hard tissues by the time you're talking about initiating bisphosphonate treatment. So it wouldn't have an effect on DI. Because once a tooth is up and in the mouth, it's not developing anymore. It's already been built.
Well, I beg to differ, and I think it's a fantastic question, by the way, because I've been looking at many DI patients now that have been in Montreal. I don't know about the other centers on biphosphonate IV since they were very young. And yes, they are discolored. Yes, they have issues, but I found, and I don't know, I didn't do the correct statistics and analysis, but I found that they report a whole lot less fractures, which I don't quite understand. If I look at my older OI population, they have a ton of fractures of their teeth. But the younger population, maybe it's going to happen later, I don't know. But it looks like maybe if it helps the bone, it should help. And Dr. Ricker is fine looking at the rate of calcification, but maybe the biphosphonates have something. And I don't know if it's true or not. So I would not venture myself saying, yes, it does. But my own observations have been kind of strange because you report tons of fractures, but I don't see them that much on the younger population, which is kind of cool, mind you, and probably is right for the baby teeth because the baby teeth do form earlier, but the adult teeth seem to be better. But that's something we should look into. Again, having a standard to at the moment, I don't know.
Thank you for answering that question. I appreciate it. And to build more on the topic of DI, can kids with DI get braces?
No.
Okay, thank you. And one of the final questions for this topic is, does DI...
Sorry, Jessica, I do apologize. Kevin, Dr. Ricker said the right thing. The problem with the DI is not so much the enamel, it's the junction between the dentin and the enamel. So if you put braces on a kid with DI, regardless of color, you don't know if this junction is strong or not. So when you want to remove the brackets, I think Dr. Napoli said that, you may remove the enamel with a bracket, which is not really what you want to do. So that's why we tend not to, on DI teeth, to put brackets on because it's too dangerous for the debonding and for the fracture rate of the teeth.
Thanks for that explanation. And does DI affect all of the teeth in OI patients?
It can vary. So some folks with DI can have a subset of teeth affected. Generally speaking, if you've got like full-blown DI, most of your teeth are going to be affected. It can be more severe in the baby teeth than the permanent teeth. And that's part of that is just the way the teeth are built. You know, the adult teeth have thicker structures. But it varies. It can vary within a mouth. It can vary within a family. It can vary kind of across the board. It's one of the challenges of all of this stuff is my mom's version of it might not be the same version that I got. I mean, they're the same genetic defect, but the presentation of how it shows up might not be identical.
Well, we'll have a study that will be published soon, hopefully, if my PhD student can finish ever. We looked at DI teeth distribution according to genes at McGill, and now we, let's say the lower incisors, lower front teeth are more affected. Some family of teeth are more affected, and we do not know why at the moment. And that's usually the front teeth are less, the upper front teeth, the lower front teeth are more, and the molars are kind of more. So it's kind of not evenly distributed.
Okay, and these next two questions deal with age. So why are children's teeth put in stainless steel caps, but adult ones are placed in caps for strength?
So with a baby tooth, our job is to try to make it last until it's supposed to fall out. When you get an adult tooth crown, they take the tooth, they either make a scan or make a mold of it, and then they either have a machine that custom fits a crown just for you out of a block of zirconia, or they send it off to a laboratory that makes something out of metal and porcelain or just metal like the ones in my mouth. And it's designed to last you forever. With kids, we only need them to last till they're about 12. So we have a box of them. We try them on like shoes until we get one that fits well enough. And the study showed that they're very successful. But crowns are kind of the preferred restorative material for grown-up teeth with DI and baby teeth with DI.
Okay. And we have another question on the topic of age. Is jawbone shrinkage attributed to age, OI, or a combination of both?
Dr. Napoli, you want this one? I think I'll start and then you can finish. It depends. The bone will shrink if you have your teeth removed, regardless of OI, the bone will shrink. The dental alveolar bone supports the teeth. If you have no teeth, you will have no bone. It's not the same as a basal bone. It's different, but the teeth that supports the bone that supports the teeth is called a dental alveolar processor bone. If you have teeth removed, it will shrink, you know? So it's not age. It's age related because the older you get, the less bone you'll have. But eventually, I don't know if the bone in OI subjects will resorb faster than a person without OI. I don't think we have ever looked into that. But I would argue that if it's a softer bone, it may actually go faster, but this is not proven yet. What do you think, Dr. Napoli? Please unmute yourself.
I don't know. I think it's going to take a while for us to figure that out.
All right. And we have another question that circles back around to implants. Are there any specific precautions that someone on bisphosphonates should take before undergoing orthodontic treatment or dental implants?
The question, I was running low on my battery. I had to scramble to plug my computer. I do apologize. Can you?
Sure, no problem. Are there any specific precautions that someone on bisphosphonates should take before undergoing orthodontic treatment or dental implants?
Well, I'll take the orthodontic treatment and Dr. Napoli will take the implants probably. So let's start with the ortho. The biphosphonates have a very long half-life, meaning that you have the medication in your body for a very, very long time, okay? So there is a fear about necrosis of the jaw if you did orthodontics. I've never read about it, never witnessed it ever. I had one case, I think, of a patient with ONJ, but that's not related to orthodontics. So I don't think biphosphonates have anything to do with any problems if you stop before. The only problem that we are still looking into in orthodontics is orthodontics works by remodeling the bone. So we resorb bone and we make bone by putting forces on teeth, right? And we think that maybe biphosphonates will not sometimes let the bone resorb so the tooth cannot move because the bone is not moving away. It's like digging with a shovel. If the shovel is not hard enough, it doesn't work. So we still don't know, but at the moment, I've been fairly successful at moving teeth even with people with biphosphonates. They seem to, some impacted teeth will not move. So then Dr. Napoli will come and help me and remove the tooth because some teeth will not move at all. The second molars is shown, we have tried to get some out, never worked. Other teeth move really well. So it's kind of still of a mystery. And that's what I'm going to leave it at there. We have no scientific data, but it looks like teeth will move with bisphosphonates somewhat slower. That's why when we do Invisalign, I will use the Invisalign for a longer period of time. But it's kind of clinical experience and not scientifically driven. But that's all I can say.
Thank you. And Dr. Napoli, did you want to add anything?
Yes, sure. As far as the implants go, the issue with the bisphosphonates in oral surgery, and mainly being addressed by those who are working in the adult world, is something called BRON, or bisphosphonate associated osteonecrosis. So that's a condition where if the jaw gets infected or it gets injured, maybe when a tooth is removed or some other surgery is done, the bone in that area dies and it doesn't heal and it dies. So, and then it becomes exposed and it can be very painful. But those situations have in general been reported in older individuals or those who are being treated for cancer and at much higher doses than may be used in patients with OI. So as Dr. Retrouvey mentioned, there's not a lot of data to make a scientific decision about what to do. So my recommendation would be to have the medical personnel work very closely with the surgeon to decide whether or not the bisphosphonates should be discontinued, how long they should be discontinued. Try to do the surgery as limited as possible if one decides to undertake having an implant placed. If the patient is smoking, definitely stop smoking, because the combination of bisphosphonates and smoking could certainly it may not be so bad and make it worse. So you know, hopefully there'll be more information about that as studies get underway. But right now, it's good. I would say it would be an individual decision between the surgeon, the patient, and the doctor who's managing the medical end of things.
I may add something to the again, I'm no implant specialist, but because I do a lot of allo treatments in my practice, I do send a lot of patients for implants who are not OI subjects, and many of these patients need a bone graft procedure where we put more bone to make sure that the implant will be surrounded by bone. And in biphosphonate/OI subjects, there is very little research to know if this added bone will take as well as it should. So that's also one issue. We just don't open the gum and put the implant in. Many times they will put a freeze-dried bone or some special bone in the around the implant to make sure that the implant will take. And that may be something that should be researched for OI subject, because we still don't know if it's going to work or not. And that may be adding to the risk of having implants. Doesn't mean it shouldn't be done, but we should research that carefully.
Thank you. I want to thank everyone for joining us. And as the Q&A session comes to a close, we would like to thank you all for submitting your questions in the chat. This will be recorded, and your questions may help someone else who may have the same questions while watching it at a later date. Thank you for joining us, and thank you again to all of our speakers. And if you have any further questions, feel free to reach out to us, and we will see you soon at the closing session. Thank you.